All right. Good morning, everyone. Thanks for coming out. We're going to talk about migraine as a systemic illness and really how we should start thinking about this as not only a headache, but really affecting the whole body. And when you think about these patients, they come in, they have not only migraine, but they have a number of other common symptoms we see and common disorders. And so after a while, you start to think, is there some kind of connection with these things? So we're going to talk about a few of those today. Objectives today, so we're going to talk about associations between migraine and the chronic pain syndrome of fibromyalgia, which we often see in these patients. We'll talk about the relations between migraine, the gut-brain axis, and we'll correlate with some GI disorders. And then we're going to understand some correlations between migraine and the dysautonomia of POTS, which we often see in these patients as well. So when I was asked to do this talk, I was trying to rack my brain of trying to figure out how I should make it and formulate it, what I should target in the talk, because there's so many different associations that we see. And I wanted to do it in a way that was somewhat unique to the patients that we see and the common disorders that we run into, but I didn't want it to be too redundant with some of the other great talks you're going to hear this morning. So I was sitting in clinic one day writing my assessment and working on that important first line of the assessment where you give the pertinent positives of the patient's history and what they're coming in to see you for, and like an epiphany had hit me. And this is actually a real story. This is a sentence that I was writing, and I think we write it so often that it just becomes we don't think about it. But these things are often in our assessment. If when you look at what you're writing. So, 47-year-old lady with a history of chronic migraine, fibromyalgia, POTS, and IBS, coming in to have her migraine managed. So this is what I decided to focus on today. Migraine is really a full body event when you think about it. Certainly beyond headache, you have pain throughout the body. 70% of patients get neck pain, shoulder pain before a migraine attack, usually during the prodromal stage. Post-drome or during the migraine, patients just complain that their body hurts, their skin hurts. So certainly beyond just the head. They're often dizzy, passing out during migraines is not uncommon. They're urinating more. They have a lot of GI symptoms, nausea, vomiting. Some patients complain of diarrhea, gastroparesis, the alternative side of that. So these are very common within migraine attacks, so certainly beyond just the headache. And then interictally between attacks, these patients often have many of these types of symptoms too. Many times chronic pain syndromes, fibromyalgia is the one we most often tend to see in these patients. Many of them have dysautonomic disorders, POTS or dizziness. They have orthostatic intolerance. They complain that their hands and their feet get cold a lot. They have Raynaud syndrome. And then they have often GI symptoms too. Chronic nausea from gastroparesis. IBS is very common in these patients, and other gastrointestinal disorders as well. So this I call this the triad, and I explain it to my patients when they come in. They tend to have migraine and fibromyalgia and IBS, and we think of these as likely distinct manifestations of a common pathophysiological process. And so it's funny, the patient will come in, they'll have two of these in their history, and I'll ask, do you have IBS? And they'll often act surprised and say, yeah, my doctor thinks I do have that. How'd you know? And then we kind of go through this that, what you have is this syndrome where your nervous system is in an overactivated hypersensitive state. So the volume is turned up maximum volume, and our goal becomes finding some way to turn the volume down as low as we can get it so you can function better, have less frequent migraine, less severe migraines. And they tend to grasp that concept often. So let's start with the fibromyalgia and migraine pain connection. And to understand this concept, first of all, we have to talk about habituation. So habituation is the normal decrement in amplitude of sensory cortex responses to repeated stimuli to avoid brain overstimulation. So you have a surgery and you have a serious incisional pain for a couple days, and the more you get up and move around, physical therapy, that pain starts to decline because you're habituating in addition to healing. And same with spraining an ankle. It's really bad at first, and then it starts to suppress pretty quick after that. So this is where your brain starts to just turn the volume down of that overstimulus of pain. So in migraine patients, they've been shown to have reduced habituation to repetitive painful stimuli from abnormal levels of activation and excitability in the cortical areas. And this leads to increased painful stimuli perception, what we know as allodynia or central sensitization, where the hair hurts really bad, they can't touch their hair, comb their hair. This is where they are just turned up maximum volume. In fibromyalgia, it also shares with migraine this concept where there's a pattern of reduced habituation to cortical areas devoted to perception of painful stimuli specifically. And again, the central sensitization spreads not only from the head where we see migraine, but we see it throughout the body more generalized. Fibromyalgia patients show this what we call cortical hypervigilance to multimodal inputs with hyperattention to painful stimuli and acoustic stimuli. And there's been studies that highlight this. And we see this similarly in migraine patients. And I think this is a really good illustration of patients we often see in the office where they just want to be on lockdown. They don't want to be going out to the concert, and they want to stay home. They don't want to go to dinner with the loud noises and smells and bright lights. They want to be in a controlled environment because their nervous system is already in a state of maximum volume. And if they add something else to it, it'll just kind of flip them into a bad cycle of migraine. So this is why, because they kind of live in this cortical hypervigilance state. Functional MRI has shown significantly greater activation of the anterior insula and the cingulate cortex to painful stimuli in fibromyalgia versus controls. And we've seen similar models of this in migraine patients during an attack and also during chronic migraine. So in general, migraine and fibromyalgia share this generalized, what we call multimodal cortical hypervigilance to various stimuli, whether it's smell, light, sound, because they have this reduced habituation there. They have this reduced ability to suppress those overactivated signals, and this is sustained by altered neuronal excitability in combination with an imbalance in those excitatory and inhibitory pain control mechanisms. So let's go through a little bit of the data. First of all, how common do we see fibromyalgia in our migraine patients? And so and this is certainly not an all-inclusive list here, but there's a few studies I picked out. One study looked at 136 chronic migraine patients. 67% of those patients had fibromyalgia. Another study of 101 chronic migraine patients, 36% had fibromyalgia. Another study with 92 migraine patients, almost 22% had fibro. And then a larger retrospective review of 223 patients showed that about a quarter had fibromyalgia as well. So what about if we reverse that? How often do we see migraine in our fibromyalgia patients? And so this is a few studies looking at that. And so there was a cross-sectional survey of 1,730 fibro patients. 56% of them, so more than half, had migraine. 55% had IBS. And this is a little teaser of what we're going to talk about next year. Another study looking at 33 fibromyalgia patients showed that 45% had migraine, 39% had IBS. And then lastly, another study of 100 fibromyalgia patients reported that 76% of them had recurring headache, with about half of that being migraine. There's this bidirectional association across studies basically between migraine and fibromyalgia. And what the data boils down to is this. About 20 to 36% of migraine patients tend to have fibromyalgia. If you look at the reverse, 45 to 80% of fibromyalgia patients tend to have migraine. So the study suggests that fibromyalgia tends to have a stronger predictive power for the onset of migraine versus the reverse of that, migraine for fibromyalgia onset. And there's been theories of a lot of this, which we're not going to get too in depth with, but low serotonin levels have been a central theory to dysregulation of the descending antinociceptive pain systems leading to fibromyalgia and migraine. And this really makes sense because if you think about it, some of the FDA-approved medicines for fibromyalgia are SNRI medications, which elevate levels of serotonin. Let's move on to migraine and the GI disorders. Visceral symptoms, nausea, vomiting, bloating, gastroparesis, these things are very common across the event of a migraine. They occur in various stages related to autonomic dysfunction. Migraine GI symptoms relate to connection between the vagus nerve and the nucleus tractus solitarius. Ictally, during a migraine, 71% of patients have some type of GI symptoms, 52% during the prodrome, so very early stage of a migraine, and 36% during the postdrome phase. So really across the spectrum of a migraine event, you tend to get very common GI symptoms. And we can't talk about migraine and GI disorders without talking about the gut microbiome. I'm not going to hit this too hard because you're going to hear a great talk on this later this morning, but I just want to put a few highlights here. So basically, there's trillions of gut microorganisms that form this ecosystem known as the gut microbiota. 1% to 2% of your body weight actually comes from bacteria in your gut. 90% of our serotonin is made in the gut, mostly by bacteria. So when you put that in perspective, this has a very strong influence on a lot of aspects, especially those involving serotonin disorders. The microbiome gut-brain axis is this concept where there's a bidirectional communication between central and enteric nervous systems with the microbiome through a variety of pathways, neural, humoral, endocrine, and immune pathways. So there's a lot of moving parts to this system, and you can see if one part of this gets thrown off, certainly the rest could be thrown off, and this could lead to a variety of associated disorders. The CNS can actually modulate the gut microbiota through the parasympathetic and sympathetic nervous systems and by also releasing neuroendocrine peptides. The vagus nerve, interestingly, sends more signals up from the gut to the brain than it does from the brain down to the rest of the body. So again, just highlighting the importance of the gut in so many aspects of health. An imbalance in the gut microbiome plus a compromised intestinal barrier leads to this leaky gut syndrome, which you'll hear a little bit more about later today. And essentially, you get this intestinal and systemic inflammatory disorders, which can relate to the leaky gut and the impaired integrity of the gut wall. Altered intestinal permeability with bacterial overgrowth has been shown to trigger migraine in some limited studies, as well as fibromyalgia development. There's been a couple of interesting mice studies, and you may have heard about these in the past, but the gut microbiome of mice was sterilized and transplanted with that of a migraine patient. And fascinatingly, these mice actually developed features of migraine, pain-seeking behaviors, whereas they did not have this prior to the transplant. Another study sterilized the gut microbiome of mice, and these mice developed a higher baseline pain sensitivity, and it was theorized in the study that it was related to CGRP dysfunction. There's been other non-pain studies that have done these similar experiments, and they've done this with obesity, with depression, and when you sterilize the gut and put the microbiota of someone with those disorders, the mice actually develop depressive disorders and activity. So very interesting how much influence the gut seems to have on so much. Chronic gut has been reported in about 56% of gluten sensitivity, 30% of celiac disease, and 23% of IBS patients. So let's talk about a little bit of the data about how often do we see these disorders in GI disorders. So about 98,000 patients in an IBS cohort were compared with a non-IBS cohort. And in the IBS cohort, there was a 40 to 80% higher prevalence odds of migraine and fibromyalgia. The prevalence odds ratio of migraine was 1.6. That of fibromyalgia was 1.8, and the combination was 2. So there's certainly some association between these disorders of migraine and fibromyalgia and IBS. And like I said, we send these cluster, I call it the triad that I explain to patients, that they tend to cluster together. Another study looking at just over 14K migraine patients were looked at in a comparison cohort, and IBS incidence was about twofold higher in the migraine cohort. If you look at the patients under 30, that was about almost 3.5-fold higher incidence of IBS in those migraine patients. Another study looking at 79 IBS patients matched with non-IBS controls showed that 32% had fibromyalgia in the IBS group versus 4% in controls. And lastly, another study of 130 IBS patients showed that about 20% had fibromyalgia. Let's move on to migraine and POTS. And this is another thing that we see very commonly associated in many of our migraine patients. POTS, or postural orthostatic tachycardia syndrome, often has a vague constellation of symptoms: dizziness, fatigue, palpitations, brain fog. By definition, POTS occurs with tachycardia greater than 30 beats per minute within 10 minutes of head-up tilt without orthostatic hypotension. So basically, they stand up, blood pressure stays stable, heart rate shoots up. And this can cause a variety of symptoms. In comparison, orthostatic hypotension can give similar symptoms, but pathogenomically occurs when they stand because blood pressure drops and can't sustain cerebral perfusion. So dizziness, syncope, presyncopal symptoms. By definition, blood pressure drop of greater than 20, systolic greater than 10 diastolic within 3 minutes of standing. So these are common things that we see in many of our migraine patients, especially chronic migraine tends to really be associated with this. Dysregulation in the brainstem, including the raphe nuclei or the lucus coeruleus, may relate to a high prevalence of pain syndromes like migraine and POTS, as well as autonomic dysfunction. There's been studies in the autonomic nervous system in migraine, and there's a mix of results here. Some of them suggest an interictal sympathetic hypofunction, ictal sympathetic hyperfunction. But this is variable. We know that there's a strong parasympathetic overdrive in migraine too, with the autonomic features that you get in migraine, and it's kind of a balance between the systems. One patient will tell you they have, when they get their migraine, they get some pupillary constriction, and then the other patient will tell you they get dilation of the pupil. And so sometimes one kind of overtakes the other. But the point is that there's a dysregulation in the autonomic nervous system, especially during a migraine attack. The hypothalamic pituitary adrenal axis has been looked at in migraine in various studies, and what it shows is there's an increased responsivity of this system. activation of stress response systems during a migraine can exacerbate many of those vascular disorders and those vascular symptoms. Stress is a very common risk factor in both migraine and POTS. And again, when you think of your patients in clinic, they come in and they tell you they had this huge stressful event and it threw my POTS out of control or threw their migraine out of control. And so dysregulation of the stress response systems is really present in both disorders. And so we certainly see this clinically with stress and the exacerbation of these disorders. POTS is often associated with GI and GU dysfunction. It's been associated with headache. If you look at the studies, the range is anywhere from 41 to 96%, depending on the study you're looking at, but clearly an association with headache. The association does tend to be greater in chronic migraine patients versus episodic. Certainly we see it across the spectrum of migraine, but when you think of your chronic migraine patients, think of it, just anecdotally, many of them come in with a POTS history in their diagnosis as well, so it does tend to cluster more with that. And there was a pediatric POTS study, and headache was the most common neurological comorbidity in this study, with migraine making up the predominance of those headache types. There are a number of other associations. Certainly there's more than just these three that I've gone over today. There's endothelial vascular dysfunctions. You're going to hear a great talk about that this morning, so I didn't want to hit too much on that. Mood disorders, very common comorbidity with migraine, likely some serotonin relation as well. Immune disorders, MCAS, you're going to hear more about the immune disorder associations this morning as well, and connective tissue disorders, EDS. So there's a spectrum of associations that we see linked with migraine. I just wanted to hit today some of the three most common that I tend to see in clinic. So in conclusion, migraine and fibromyalgia share this generalized multimodal cortical hypervigilance. So their volume again is turned up maximum volume to various stimuli, whether it's light, smell, sound, and they have this reduced habituation to pain. So they have the nervous system that isn't able to suppress those repeated pain stimulations, and they tend to actually enhance. And so this is sustained by neuronal excitability and an imbalance in the excitatory versus inhibitory pain control mechanisms. The microbiome gut-brain axis creates this bidirectional communication between central and enteric nervous systems with the microbiome, and this occurs through a variety of pathways, including neural, humoral, endocrine, and immune pathways. So again, if something in the system gets thrown off, such as the gut microbiota, you can get a lot of downfall from that in other not only neurological but other medical disorders. And imbalance in gut microbiome can contribute to migraine. That's what the evidence suggests. Migraine and POTS both share dysregulation of the HPA stress response systems and dysregulation of the brainstem nuclei, including both pain and autonomic nervous system imbalance, are kind of central to both of these disorders. Lastly, I put together about 50 references here that really support all these associations that we've talked about today. And that is it. Thank you.